this morning after last night's festivities. I want to introduce Dr. Peter Favini. Dr. Favini has been a medical command physician since 1984, residency trained in emergency medicine, and EMS agency medical director for 25 years. Dr. Favini is a former member of the Eastern PA EMS Council Board of Directors and is currently a member of the Medical Advisory Committee. Dr. Favini currently serves as an agency medical director for a number of agencies throughout the Eastern PA EMS Council and EMS of Northeast PA. Dr. Favini obtained his medical degree from Temple University School of Medicine and has been practicing medicine for 32 years. It's my pleasure to introduce Dr. Peter Favini.
I sound pretty old after that, and I actually am pretty old. But we have a scholarship fund, and I'm going to bring up Pike County. We do Paramedic Scholarship Fund, and these guys are nice enough to present some money. And these are my representatives from Monroe County Ambulance. And so we're going to have just a check presentation real quick. Jeff, guys, I was going to say, Celia, for a picture, but you're way ahead of me. Good. Thank you, guys.
I'd like to give you $500 towards your scholarship fund.
Thank you. Denise is our treasurer. Pass that along. You'll hold that. Get together.
Get it close. Perfect.
Thank you, guys.
Thank you, guys.
Thank you so much.
Thanks, guys. So Monroe County Ambulance was nice enough to set up a scholarship on my name. The first year they set it up, they hung up all signs all over the hospital. I'm coming out of the break room, and one of the nurses is there and looking at the scholarship thing and goes, "When did Dr. Favini die?" I was like, "No, I'm still alive." Wait, stab her on the shoulder. I'm still alive. It's okay. So, but it's very nice that we can send. I think last year sent 2 people through school, so it was really good. And one is currently working actually for us, so it's really good. So I'm going to talk about critical care anywhere, and actually, if you guys are okay, I'm going to start with a little video because it runs better if I start it on its own. So what I'm going to talk about is critical care things that you can do today and also will do in the future that are interesting or changing. So some of the stuff is brand new and is going to change, and you're not doing it yet. Some of the stuff you probably will do over the next 5 or 10 years, so it's kind of interesting stuff. This is from the Lancet, an interesting thing just for SVT. So you have a patient who has an SVT. Classically, we used to massage on the carotid. No one does that much anymore because they're worried about producing a stroke. But this is actually just came out in the REVERT trial for SVT. This is the author. He talks about, use it to show you the maneuver. Basically, they take somebody and they have them do a Valsalva maneuver, which for them is blow into little tubing and just produce pressure in the manometer. And then they raise the legs. So the big difference is they have people bear down and then they raise their legs. Well, as you can have them bear down. So you have them blow into this thermometer until it hits about 40 or so. And you can do the same thing with the syringe. Just take a 10 cc syringe and have them blow into it for about 10 seconds. And then they just drop them back. And usually for SVT, so for supraventricular tachycardias, if you're running fast, the conversion with vagal maneuvers, so you see somebody's in the SVT and then they pop in the sinus, that conversion is probably 10 to 20%. So it's not real great. Most people just bag it and go right to adenosine. But for some people, if you can't get access, or a young person who's afraid to get access, they do this maneuver where they just have them blow into that tube, and he'll show you they have them blow also into a syringe. And it just basically produces the Valsalva maneuver, and then they just raise the legs for 10 or 15 seconds. And the conversion rate now for SVT doing this goes from about 10 to 15% to about 40 to 50%. So we actually started doing this at Anderson. We had 2 patients over the last 2 weeks, both converted. Boom, just like that. The nurses were just amazed. So you guys are blowing in the syringe. So same thing. It's easier to do probably than anything else. So blow in the syringe for 10 seconds or so, just a Valsalva. And then again, drop his head, raise his legs for 15 seconds. And again, conversion rate goes to about 43%. So really a neat little adjunct for us if we can't get access, or if you are having trouble with the patient, or it's a young patient you don't want to put an IV in. So I was going to throw that at the end, and you'll see the slide at the end, but it ran better from the start. So let's talk about tools you can use now and in the future. this is my first case. See if this will run.
Okay, we've got a 50-year-old male, unrestrained driver, high school, walking the telephone pole, was ejected, and constantly arrived. Intubated first pass, 2 IVs, last BP 65 health, pulse 120, small active. Okay. Obvious breakthrough fracture. Let's get him over to stretcher. 1, 2, 3.
No pulse. So this is a guy, so I think my other video is running in the background. So this is a guy, hypotensive, tachycardic, no pulse. Yeah. Let's get rid of this. He's going to keep talking if I don't shut him up. Okay. So my patient is hypotensive, tachycardic, blunt trauma, has a femur, has a pelvic fracture, right? So what do you think of this guy? Hypovolemic shock, yeah. So, and then no pulse. So what are his odds of survival? Like 0, right? Pretty much 0. I mean, I don't think I've ever seen anybody resuscitate from this. So what do we currently do? Well, you know, pelvic fracture, exsanguinating patient, pretty much a dead patient because no volume. You're not going to be able to really get enough volume into this person that they're not going to bleed into their pelvis or into their femur. So currently it's really transfusions, maybe a pelvic binder, and just pelvic stabilization, and they're still going to be dead, so you're going to run a resuscitation. So in the old days, why would we do this? This open thoracotomy. So we'd open the chest. Why would we open the chest? Because really wasn't anything else to do. We'd open the chest and basically cross-clamp the aorta. So try to keep the blood volume from going to the pelvis and going to that femur fracture, cross-clamp the aorta, and then just try to resuscitate from above. So it's a huge maneuver to do to open somebody's chest. And to be honest with you, most times we did it for practice on the people who maybe we could save later. You know, because, I mean, stab wound, I've had 2 open thoracotomies in my career, and both have survived, but both were stab wounds to the chest. So all the blunt trauma thoracotomies, I've seen people do them, but they don't resuscitate. But yeah, that would be the plan. The plan would be open the chest. You can directly massage the heart. You can get your blood volume back to the upper extremity if you can by clamping the aorta. So what else can we do? Well, Reboa is coming, and it's basically in field trials at different places. And actually, someone from Commonwealth told me yesterday they were talking about Reboa from their trauma center. So it's coming. Jim Cipolla follows me. You could ask Jim about Cipolla. He's one of the trauma docs at St. Luke's. And so what are we talking about? We're talking about taking a catheter, a balloon catheter, sticking it in the groin, so femoral artery on this side. They're putting a catheter in this guy's left femoral artery, threading it up, and basically occluding the aorta from above. So balloon, just like we put in big IV lines, stick in the femoral artery, threading a catheter up, and basically occluding the aorta right there and stopping the bleeding to the pelvis. So it's a temporizing measure, but does it work? And that's the question, and that's what kind of trials are trying to prove. This is an old technique. 1954, there's a guy named Carl Hughes, who was a combat surgeon who, in Korea, did this to 3 soldiers. Now, they were able to resuscitate them, but they all still died of bad injuries. But it's been around for a long time. And the question is, you know, how can it work and how can it work? And do we have the techniques now? So we all, in those days, they were cutting down on the femoral artery. Nowadays, we have the Seldinger technique where we just put a wire into the femoral artery and then thread the catheter up. So that's what we're looking at. We're looking at putting a big catheter in the femoral artery. This guy has a catheter on the right side. He also has a pelvic binder on because he has a severe pelvic fracture. And then threading it up, and the techniques are getting better where they'll occlude different zones as far as where the injury is. But if you think about it, you know, a lot of these people exsanguinate from pelvic fractures, they exsanguinate from solid organ injury, and if you can just prevent blood supply to that area for a short period of time until you can get in there and either fix the hemorrhage, stop the splenic hemorrhage, stop the liver lac, or pack the pelvis, or stabilize the pelvis, or interventional radiology for the pelvis to try to stop that bleeding, then you can open the balloon back up and let the circulation come back. Why is this becoming more and more thought of as possible? Well, when they fix abdominal aortic aneurysms now, a lot of the aneurysms they're doing with stenting. They basically put a stent inside somebody to prevent the aneurysm from rupturing. So if you're leaking or something, they go in, and when they start to maneuver and manipulate the aorta, they balloon it. So it's becoming a fairly common technique in vascular surgery to balloon the aorta, stop the circulation, and then work on the aneurysm. So for trauma, why not just occlude the aorta and see if we can get, resuscitation, get them enough blood volume back that we can perfuse the upper extremity, and then if they're alive, take them to the OR and try to fix the stuff that's all broken down below. Here's a look at the balloon catheter in the aorta on fluoroscopy. So basically, they've threaded the catheter up, they've inflated it. So it's a large vessel occlusion of the thoracic aorta. So REBOA is resuscitative endovascular balloon occlusion of the aorta, or REBOA. It's a temporizing maneuver, but it's basically to try, opposed to cross-clamping the aorta where you have to enter the chest, we're really trying to get a balloon catheter up there and basically stop the bleeding to the pelvis. Cool. So it's in trials. It's called the aorta trial, aortic occlusion for resuscitation in trauma and acute care surgery. It's ongoing at multiple trauma centers now, and maybe coming to a trauma center near you. Or again, I see it going pre-hospital. So you get to a scene, it's a pelvic fracture, bad car accident. If you can throw the REBOA in and it works. The catheters are big now. They're going to have to come down in size. The pressure in the catheter is going to be important over time. So there's going to be more science involved in how to design the catheter. But I really think it's down the line, it's really going to work, and it's something that we may be able to save some of these bad pelvic fractures. Okay, so that's the future. So Pete, you're asking me, what can we do today? What is it today that you want us to do that would help our patients? So Valsalva is one, and then I have some other things. So head of the bed. How many guys are looking at elevating the head of the bed in their patient? So you intubate somebody and you think, well, can I leave them flat? Now, if the cervical spine's bad, leave them flat. But for a lot of people, post-intubation elevation of the head of the bed really prevents ventilator-associated pneumonia. So 10 to 20% of these patients, if they're left supine, will develop ventilator-associated pneumonia. So the key early on after intubation is really try to bring up the head of the bed. So if you get a ventilator-associated pneumonia, you're twice as likely to die in the ICU. So it's one of those things whenever we intubate now, try to raise the head of the bed, and that way prevent secretions from kind of going down the lungs and stomach secretions and aspiration. And it really, again, in the long term, it helps the patient. So something simple you can do today, just throw it in as a tip. The other thing, what else does elevating the head of the bed do? Well, when I intubate now, I elevate the head of the bed a lot. And this picture is kind of a classic, but it's really why. So here's somebody who is a big person, which is not uncommon these days, and we've elevated the head of the bed to kind of straighten her airway out. And if you look at her angles for intubation, flat, and you guys have all seen this where you kind of come into a house and basically the person's flat and you just look at it and there's like absolutely no airway with them flat like that. So building a ramp in some way, so either bringing the head of the stretcher up, or, and this lady, they've ramped her up with a whole bunch of linen just to try to get her angle. And if you look at the angles, that, flat, she's got absolutely no intubation angle. But upright like this, once you sneak the blade in, you may be able to kind of see around the corner. So that's really an advantage, and it's really helped me. That and really a two-handed technique with intubation, where sometimes I'll go in with the scope and lift, and then I'll take my other hand, have somebody hold the tube, and I'll move the larynx around so I get it aligned. Then I have that person hold the larynx for me, and then I take the tube and I put it in. So two-handed intubation in these people is helpful too, where you basically just have an assistant hold the tube, you do the laryngoscope, you move the larynx around so you get a better view, and then have them hold while you take the tube and go in. Anybody using video laryngoscopy in the field? Using the field? So great technique. Ron Walls is the big airway guy. 10 years ago, Ron said, video laryngoscopy will be the norm in 10 years, so he's wrong. But it's coming, and the problem is that video laryngoscopy is expensive, a laryngoscope is cheap, so that's really the biggest change. And laryngoscope is successful. It's successful, probably better than 90% of the time, but it's those 10% of cases or so which are difficult. So ramp up the head of the bed for two reasons. One is for your view, for ease of intubation, and the second part is really to prevent aspiration. Okay, so more questions on that? Questions on REBOA before I leave REBOA? Sure.
Have you ever done any tests with the abdominal tourniquet, like a functional tourniquet?
Yeah, I'm really old, and I remember the mass suit, to be honest with you. So.
Field tested in the military, it seems to work for
There's-
the pelvis
there's amazing stuff coming out. I mean, it's kind of sad, but the more we're in combat, the more things advance to trauma. And so pelvic binding, abdominal tourniquet, the tourniquet where you really apply abdominal pressure does seem to work. So that may come. So I thought Ribot was interesting just because it's a really neat way of basically cross cramping the aorta. But abdominal tourniquet, I think, too, will probably come over time. Yeah, a lot of the stuff from Iraq and Afghanistan, narrowly now, people are starting to push stateside to say, tourniquets are back to a large extent. I have a little thing about the injectable adhesives going forward, blood clotting stuff. So, good thought. Yeah, if anything, if you have a question, just raise your hand. And again, my purpose in life is to entertain, and I think education then comes along as opposed to be boring. All right, so the dopes mnemonic, a lot of you guys probably know this, but I use this all the time. Like, so I have someone that I intubated, maybe they're on a ventilator, and then there's suddenly a problem. What do I do? What do I think about the tube? How do I think about the tube, and what's wrong with the tube, and why isn't the tube working? And so I got to go back and listen to the patient, listen to both sides, and see if I'm ventilating and see if the ventilator is getting volume in, or take them off the vent and bag them and see if I can get the volume in. But I think of dopes, so I think of really these 5 things. So is the tube displaced? So that's the thing, is the tube should be sitting in the larynx, and it's not uncommon with kids. I'll tell you, I can talk a little bit about peds intubation at the end of the talk, but not uncommon with kids, just flexion, extension of the neck will pull your tube right out. If any of you guys have experienced that, the tube, they're so small, the anatomy is so small, so just moving them to the stretch, over to the stretcher, I've seen the tube come out very easily. So did it displace the tube? So our tube was in the trachea here, and now our tube's in the esophagus. So think, did we displace the tube? And usually you get that from CO2 return, or you listen for breath sounds, or it sounds different, and you feel the air coming back as opposed to going down the lungs. So we did displace the tube. Is the tube obstructed? When I first took ACLS as a resident in 1983, and usually I say that and people start to talk, oh, I wasn't even born in 1980. I know, okay. So the senior residents used to do this thing where they put a clear marble inside the tube, and then they hand you the tube to intubate, and then you couldn't ventilate, and you didn't know why, and kind of the valve bag kept popping off, and you'd be like, oh, and people would cry, and then they pull the tube out and go, look, the tube's obstructed, you idiot. And so we don't haze people like that anymore, fortunately, in medicine, but think of tube obstruction. So it'll obstruct from blood. We had a lady intubated, actually one of the first intubations I did at Anderson. I put the tube down and pulled it, couldn't ventilate real well, pulled the tube back, gum. She had a piece of gum in her mouth. She had bled in her head, passed out. As I intubated her, she had gum in her trachea, and fortunately got caught in the tube. So think of a tube obstruction. This is a tube obstructed with a blood clot. So just think about it. It's one of those things. I had a kid very early in my career who had a tube obstruction. I pulled the tube, re-intubated, couldn't ventilate the kid. On autopsy, the kid had swallowed a little piece of a balloon that had deflated, and it was sitting right in his trachea. So my tube was going down, sitting on that balloon, and I couldn't ventilate. And so I don't know, other than trying to pull that out, but it was too low to pull out, or popping it in some way, I think that kid was going to die no matter what. But that's what you think. It acted like a tube obstruction. I went through tube obstruction in my mind like a million times, still could not ventilate. So think of tube obstruction. Maybe if I put suction on the tube and pulled it back, I could have got the balloon out if I knew it was there. But parents just knew he had arrested. They thought he had choked on something, but we didn't know. So think about it. Pneumothorax. So, listen for breath sounds. Look for, splaying of the lungs of the ribs where the ribs will separate for you. Usually you can kind of feel if the cardiac PMI, the prominent cardiac pulse will shift to the side. So think of pneumo. And usually you see it on chest x-ray, but obviously if you get a tension pneumo, then you have to do something about it. Equipment failure, so if your bag is bad, or if you're not ventilating, or you start to desaturate and you think you're not hooked to oxygen, or if you're doing bag valve mask and you're not getting a good seal, so think of equipment failure as the E. And then the last thing is breath stacking. Does anybody have a lot of experience with breath stacking? So what I mean by this is it's really when you have someone on a ventilator, or if you're bagging somebody and say they're a bad asthmatic, you can actually, they need time to expire. So, this time of spring and fall, we see a lot of croup, and those are kids that have that upper airway sound. And then we see asthmatics who have lower airway disease, so their sounds are really expiratory. They're the wheezers. as they breathe out, they get that nice wheezy sound. So they need time to expire. And a lot of times when we bag them or we put them on a vent, they don't have that time to blow out. And so they tend to stack air. In other words, they get more and more, as we ventilate them, they get more and more air in their lungs. And the problem is their lung volume becomes to the point where they don't really get good venous return. So here's basically somebody, you drop your diaphragm, basically the pressure goes down inside your chest, you breathe in, and then hopefully you breathe out, and that volume goes out. But if the volume's not going out, you really get kind of locked in. And I've seen people, asthmatics on a vent, who will just have no venous return. They drop their pressure, and then they arrest. So what do you do? So basically, pop them off the vent, pop them off the tube, don't bag them for a minute, let them breathe out. Or the other thing to do is just kind of gently compress the chest a little bit. And you can see this in asthmatics where they'll get really full, their chest will be really tense, pressure starts to drop because they don't have good venous return. They can arrest on you or get very bradycardic, and then you look at their chest and it's full, and the respiratory therapist, or if you're bagging, you'll feel that there's a lot of pressure. Pop it off, decompress the chest, just let them either blow out for a prolonged period of time, or just really put your hands on the chest and squeeze down. And I've had a couple of bad young asthmatics who, late teens, early 20s, where you just compress the chest, you get this prolonged like wheeze coming up through the tube, and then you can ventilate again. It's pretty amazing. So the essence dose is really breath stacking, and dopes is breath stacking. Good. Questions on that? So tube obstruction, something you can kind of use every day. And most people know that mnemonic, but I just thought I'd kind of review it. And then think of breath stacking. All right, apnic oxygenation. Anybody heard me talk about apnic oxygenation before? No? Good. So what is apnic oxygenation? So basically, for years, I went to intubate somebody, the nurses would have the nasal cannula on, and I just ripped the nasal cannula off. And they'd be, if I couldn't get the tube, they'd be putting the nasal cannula back on, and I'd have paralyzed the patient. So I'm thinking to myself, well, what good is this nasal cannula? Turns out, like most times, they were right, and I was wrong. The nasal cannula does help. It's amazing. So basically, just leave the nasal cannula on and crank it up. So what are we looking at? We're looking at this paper by Scott Weingart and Rich Levitan from the Annals back a couple years back, and they basically said, if we take patients, we leave them on nasal O2, we crank the oxygen all the way up, and we paralyze them, they still oxygenate. It's pretty amazing. 15 liters of nasal O2, you would think, well, patient's not moving any air. How is it possible? But those patients continue to ventilate, continue to oxygenate. And it's true. It's been around for a long time. It's not a new concept. Really, for years, people have been talking about just basic passive oxygenation, and the terms were apnic diffusion oxygenation, diffusion respiration, mass flow ventilation, and basically it's just a way of oxygenating the person kind of while you're doing an airway maneuver, but even if the person's not breathing, you're going to be able to oxygenate them. So really kind of been a revolution in my career to say, let's leave the nasal cannula on and let's crank it up. So why does it work? Well, your alveoli, because they absorb oxygen, they're pulling volume out of the volume that's in there. They're pulling the volume of oxygen across the membrane. So there's a passive kind of flow of this stuff of you throw oxygen in, basically the oxygen hits that membrane, gets pulled across, and there's a pull downward of oxygen into the lungs. It's a passive flow. So when you think about it, they're continuing to take up oxygen even without diaphragmatic movement. So there's no lung expansion. But the apnic patient gets about 250 cc's per minute of oxygen that will move right into the bloodstream. So there is some flow. Basically, you're not going to blow off carbon dioxide, but you're going to continue to entrain oxygen down there. It's going to continue to cross the membrane. So basically, this is the standard now. So what I'm doing is just leaving the cannula on. So it looks kind of weird because the guy's paralyzed. He's not breathing. But I got the nasal cannula on, and I got it all the way cranked up. And it really causes, you're getting a positive airway pressure in the upper airway, you're getting oxygen in the upper airway, but you're getting that diffusion down into the lungs, and basically as they absorb the oxygen, they suck it on down. And it's funny because in the old days you would, and it was always annoying because you'd take everything off, you put the blade in, the patient's on room air, basically, you're trying to intubate, and there's always that nasty nurse who's sitting next to you going, Doctor, 95, Doctor, 90, Doctor, 85, Doctor, 80, Doctor, 75, Dr. 60, Dr. 60, and you're like panicked and you're trying to, and now with this, it's really, you put the oxygen on, you crank it all the way up, and you put the blade in the mouth, and you have a couple minutes where the sat just sits there. It's amazing, it just sits there in the 90s. So if someone's, even somebody unconscious, they'll tolerate nasal O2 at this volume. Just crank it up while I'm getting ready to intubate. You know, people can continue to bag, still use them, you know, use a mask. You can still ventilate if you have somebody there who's ventilating. But while you're intubating, it's a nice adjunct to really just crank up the oxygen. So no spontaneous ventilation. So, and it's funny, it's been studied for years back. If you look at old studies in like Navy volunteers, where they took guys and they just paralyzed them with a nasal cannula on, and they cranked up the nasal O2, and then they woke them up after paralysis, and they were fine. It's a study you'd never be able to do today, but it was done in the 40s, where they just basically, you know, stopped oxygenating people other than nasal O2, stopped them from breathing, and they maintained their SATs. And so really for under optimal conditions in a healthy person, now in a sick person who we're intubating, it's not going to be as well, they're talking about PO2s of greater than 100 without a single breath for over 100 minutes. So it's pretty impressive. And then again, sicker patients are going to desat faster, but again, it's only an adjunct, so it's better because you're oxygenating, trying to oxygenate while you're putting them down, or while you're trying to intubate them. You're going to get hypercapnia. Their CO2 is going to climb because you're not ventilating them. They're going to get acidotic. But it's a nice adjunct because you're going to do the same thing anyway. And it's basically a nice benefit. So leave the cannula on, crank up the nasal O2. Usually my unconscious patients or my paralyzed patients, everybody tolerates 15 liters through their nose. If you crank it up as much as you can, having the mouth open doesn't matter. They make a nice reservoir of oxygen in the back of their throats, and then they suck that down. And basically it's like a no, they call it no desat, so no lack of saturation. So try it next time if you're intubating. It saves you that panic of having the O2 fall while you're putting the tube in. Questions on apneic oxygenation before we leave it? So nasal O2, the nose knows is what they say, you know, think of the nose, so go through the nose. Post-intubation sedation. So this is a big, this for me has kind of always been a big problem. I feel bad for these patients because they come in hypoxic. They usually, you could paralyze them, and or some people just let you intubate them because they're out, and then you start to oxygenate them, and then they wake up. And I remember being a resident early in my career, and I would, before I was really comfortable intubating, I'd get these bad, like people with CHF, and I would just literally bag them a little bit. They'd wake up, they'd pull the bag off their face, and then they'd desat, and then I'd get back and bag them. So it was like, the nurses were like, why are you fighting with these patients? Like, just intubate them. So it's really true. Like, you oxygenate them, they wake up. So even if you tube them, they wake up, they want to pull that tube out. And so it's an uncomfortable sensation. And so what do you do? I mean, you can keep them paralyzed, but that's miserable because they wake up and they're paralyzed and they can't do anything. So, and you guys, you can't paralyze in the field, obviously, unless you're with a flight crew or something like that. So having a tube in your airways is anxiety-provoking. It's painful. If you're awake, you really feel it. You want to get it out. And these patients, sometimes we give them drugs, and then they get hypotensive. So we tend to give them like benzos, and they get hypotensive. Or there's a whole push now to prevent ICU delirium. So the patients who get delirious are much more likely to die or have comorbidities. And benzodiazepines have been kind of associated with inducing that delirium. So what do you do? And most times in the field, we're still going back to benzos. But think about fentanyl. The Critical Care Society says now they recommend fentanyl as a first-line drug for people who are intubated. And I found in my practice, just 100, you intubate them, 100 of fentanyl. We usually do use propofol, and people will start propofol, but it takes a while to get the propofol dripping up. And just 100 of fentanyl, a lot of times they'll ignore the tube. You can add benzos. You can start to add some Ativan if you need to, if they're really anxious, if they still want to pull at the tube. But fentanyl's a nice starting place. It doesn't drop the pressure. There's no histamine release. Most of you guys have it now because it's basically cheap. It's become cheap after it's come off formulary.
Now, obviously, what happened now? What about in the future? Now that the state's starting to get more appreciative towards ketamine.
Ketamine's a great drug, and I would use ketamine too. Now, the hard part in older patients, ketamine will make them tachycardic, and you worry about a little hypertension in ketamine. With ketamine. So if you're really worried, if somebody's pretty fragile and maybe have heart disease, you just worry about inducing a real rapid tachycardia. But in a young patient, ketamine's it's golden. I mean, I'll tell you, because I've intubated just straight with ketamine, and no paralytic, nothing else. Just put them down with ketamine, It's excellent for us for procedures, and even the RAMI patient, the agitated patient now, 5 milligrams per kilogram IM ketamine. So you got to hold the guy down, he's hurt, but he's fighting you. 5 IM ketamine, 5 milligrams per kilogram IM ketamine, so like 300, 500 in that range. They go down, you can play with them, you can do stuff. You usually don't even have to intubate them if you don't want to, because they protect their airway. It's a great drug, so I agree with you. It's a nice adjunct. City of Allentown, anybody here from the City of Allentown? We did ketamine, their medical director did ketamine for them with all the K2 that they've had. So they had a bunch of K2 patients who they're fighting, they're RAMI, you can't control them, they might be sick, or it might be hyperthermic. But, what do you do with these guys? So 5 mg per kg, IM ketamine, they go down, then we can work on them. So it's really very nice. So it's a great drug. So yeah, if you get ketamine in the field, I think it's perfect. And ketamine, even just at lower doses for disassociation pain control, is really nice. So that person who maybe's RAMI, you can't get out of a vehicle, if you get an IV, a little bit of IV ketamine, they're much easier to control, and you can just disassociate them enough so they don't care about their pain, but they'll talk to you. I think it's a great drug. Occasionally you get somebody who gets a little RAMI on ketamine because it's like a PCP derivative, but you add little benzos and it goes away. But most people I find just kind of like chill out, or again, if you give like doses where you completely disassociate them, you could stand on them, they don't care, and they ventilate and they maintain their airway. So it's a great drug. I agree with you. So think of fentanyl in these cases. That's again, for me, my first drug was really, where's the propofol? And the patient starts fighting, and the nurse is grabbing the propofol from somewhere, and milk of amnesia because the stuff is white. And then, but it takes a while to get it, and then I'm usually adding a benzo, which I start to worry, how long is it going to last, and if they go to the ICU, are they going to be, going to have dementia, and delirium from the benzodiazepines. So think of fentanyl, because a lot of these people, you give them fentanyl and they just kind of chill a little bit, and then you really can add another drug if you need it, but it's actually very nice. So Critical Care Society says, good way to start, and I use much less benzos now, and I use much less propofol now because of fentanyl. All right, dirty epi. Anybody know about dirty epi? Dirty epi. So yeah, good. So I use dirty epi, not a lot, but it's a nice way to use epinephrine. So say you have here's somebody with severe facial swelling from an allergic reaction. Here's somebody, this guy actually has angioedema, probably from an ACE inhibitor, but say you had an allergic reaction that looked like this. So we're going to get airway swelling, you're going to get bronchoconstriction, you're going to get cardiac malfunction, you're going to get vasodilatation, and you're going to get like a bad skin reaction. So you give epinephrine, which is the drug of choice, and the Allergy Society says, use epi, please use epi, because it really does work. And you don't have to use epi all the time for the anaphylactoid type reactions where people just get hives. We use antihistamines and steroids a lot, but if it bothers their airway, if they get swelling, severe swelling, epinephrine's a godsend, and I really think it's a great drug. But say you give an IM epi and their airway is still very swollen, or the classic thing is they're really hypotensive, they look like crap. My favorite allergic reaction case that I've ever had in my career was a dad calls the ER, he's in a Jeep, he's driving an ER, and he says, my 16-year-old son was cutting the grass, he ran over a nest of hornets, he got stung a couple times, and I found him passed out in the lawn. I'm bringing him in, and so I grab, we don't really carry EpiPens, but I grabbed epinephrine, pulled it up in a syringe, 0.3 cc's of epi, just like an EpiPen, and I run out into the parking lot, and up comes this Jeep, swerving into the parking lot, and I look, and in the front seat, not even in the front seat of the passenger side, but on the floor is this 16-year-old kid, and he is just pale and poorly perfused, and he has no pulse, and he's like this, like underneath the dashboard, and so I just hit him with 0.5 of epi in the back of his neck. Fortunately, I didn't hit like a major vessel or anything like that, and pulled him out of the front seat of the car, and as we laid him on the stretcher, he starts to breathe. As we roll into the ER, I can feel his pulse coming back, and once we got into the trauma bay, he's starting to move around and breathe and starting to talk. So epinephrine is really life-saving in those cases, and that's why people have it. But say it fails. The treatment then is IV epi. And IV epi is kind of hard to give because there's been cases where people have taken a whole amp of IV epi from the code cart or from your bag, given the whole amp. So that's a whole milligram. It's way too much epi, and people have had heart attacks. You know, somebody at my age, give me an amp of IV epi, I could have a heart attack just from the administration. So you saved me from anaphylaxis, but I die. The big case was 83, front page of front of Annals on a Detroit Receiving, where they gave somebody IV epi, and next thing is big anterior wall of my. They published the EKG, so it was amazing. So don't do that. So how do you give 0.1 of epi? So 0.1 milligrams. So that's the dose. The guideline is push 0.1 milligrams. So 1/10 of your syringe, or if it comes in the small vial, 1/10 of that. So it's a high-risk drug. So I use dirty epi, and what that is I take the amp, or I take the 1 milligram that comes like this, and I put it in a liter of saline and just mix the bag real quickly. And so then, for every cc in the bag, it's basically, the milligram goes basically into a liter. So it's the milligrams, it's 0.1 microgram per cc. I think I put milligrams there, sorry. It's 0.1 microgram per cc. So I can open that and run it wide. If, say, someone has no blood pressure and I'm thinking they're dying, I can run that wide, and if they get the whole bag, which is going to take a while, that's a whole milligram, but 1/10 of the bag, so 100 cc's, first 100 cc's is going to be that 0.1 milligram that I want, and then I keep going from there. And then if I start to get a pulse back, I can slow it down, and then I've basically made a dirty epi drip, and I have an epi drip that I can use and start to give them that milligram over time, or if they get a nice pressure back, I can just turn the bag off. So it's a nice way of basically quickly getting the drug you need in a concentration that's not going to kill the patient or hurt the patient. So basically an amp or the small vial, bang into a liter, shake it up, give the first 100 cc's quickly. That's going to be 0.1 milligram. That's the recommended dose, and it's a dirty epi drip. Here, I have the right dose right there, 1.1 microgram per cc. Good. Questions on that? Sure.
I'm sorry, you're just calling it dirty epi because you tainted it with saline, is that why?
Yeah, because here's what happens in the hospital, to be honest with you, and to be totally candid, here's what happens in the hospital. All right, we get this guy, he's hypotensive, his airway's swelling, we need an epinephrine drip. The nurse calls pharmacy. Hey, pharmacy, we need an epinephrine drip. Oh, really? What concentration do you want? Oh, Dr. Favini, he wants 1 microgram and a cc. Okay, I'll be up in about 45 minutes with it. You know, so by then the patient's dead. You know, like they're long gone. So that's why I think over the years people have pushed whole amps, because you know you got to give the drug's recommended. You could try to push like 0.1 of the amp, but then you know sometimes people get very tachycardic or can get hypertensive from that. You can kill somebody with the whole amp and epinephrine. So it's basically a dirty epi drip because we're mixing it ourselves. We're making a drip ourselves, but it's a clean way to do it quickly. And it really, if you have an anaphylaxis that failed that initial IM injection, and why would they fail? You know, the EpiPen. Well, sometimes your perfusion is bad. If your blood pressure is low, you're not going to perfuse the muscle. You might not get the epinephrine. So if you can get an IV drugs are the way to go if somebody's that sick. So basically it's dirty because we're doing it ourselves without the pharmacist, but we're saving the patient. So that's good. Questions on that? Good. Tranexamic acid, anybody using this, or anybody heard using this? Yeah? Are you using it in the field, or using, yeah, for flight, or, yeah, medevac, or? New Jersey. I know medevac is maybe starting to use it too. So tranexamic acid is basically, it's like an amino acid. It's similar to lysine. But basically, the International Trauma Life Support Agency has basically said, hey, this is something we can use for hemorrhage. So it's a synthetic analog of lysine, which is an amino acid. And basically what it does is it prevents clot breakdown. So when you clot, you make plasmin, and you basically make TPA on your own to break that down. Plasminogen goes to plasmin, and it basically prevents that step. So it prevents you from breaking down clot. Our bodies are constantly in flux. We make, you cut your finger, you want to make clot. In your leg, you don't want to make clot because that's going to go to your lung. You know what I mean? So our bodies are constantly in flux and making clot and not making clot and dissolving clot. And so if I get hit and I rupture my spleen, I want to make clot, and I want the clot to stay there. I don't want the clot to move. But my body says, hey, we don't want clot around all the time, so we make clot, and then it breaks it down. Then we make more clot. So hopefully, if I'm healthy enough and it's not a big enough injury, I can clot it off. But sometimes the clot will break down, and then I start to bleed again. So in those people, if you have a severe hemorrhage, if you use tranexamic acid, you can make them clot and maintain their clot. So we're looking at really giving first a gram over 10 minutes, followed by a second gram over 8 hours. And actually, fire department in Newark, Ohio started this a few years back, and they've had a bunch of what they think are saves from this. So nationally, if you look at it, it's really becoming a vogue to say, hey, if there's hemorrhage, can we give something to really prevent that clot from breaking down and save those people? So tranexamic acid is a way to do it. There's 2 big trials, CRASH 2, 2 big trials about this versus placebo, and it seems like it does save lives. So they just give in Newark, Ohio, they hang a gram and basically give it over 10 minutes on their way. Their transport times are about 45 minutes an hour, so they really need something to try to keep these people alive on transport. So they've been using tranexamic acid.
Do these work once person's in TKA already?
If somebody's like if they in shock, like they bled, yeah, you do use up all your clotting factors at some point. So DIC. So if you're in DIC and you've used up all your clotting factors, it's not going to work. But in those people where they've made clot and then they're continuing to break down the clot, it prevents that breakdown. So there's a window where this probably helps. But this that's why I think they have a very active medical director in Newark, and he's basically said, our transport times are so long, rather than let somebody bleed to death, why don't we try this? It seems to be working for them. So I think, again, a lot of the flight crews are starting to stock this because it's one of those things where, hey, if we have a 45-minute flight, a half-hour flight, maybe we can get this on board and prevent some bleeding until they get to the trauma center. Okay, injectable clotting materials. So these are coming, and talked a little bit about tourniquets and stuff earlier, but we're looking at stuff that you would directly inject like into the abdomen or into a wound, and there's a whole bunch of them now in trials to basically, basically shove in a wound and try to stop bleeding. Polystat is the one I kind of like. There we go, sorry. Go back. Polystat is the one I wanted to kind of talk about. So basically it's a polymer, kind of looks like that, and basically it binds together with your clotting factors and tries to cross-link your fibrin and make it so it doesn't so you don't bleed anymore. So it works pretty well. So these are coming really for the tourniquet kind of cases where you got somebody who's bleeding, but you really can't get a tourniquet on the area, or it's an active arterial bleed and you really can't compress it. You can stick this in the wound and try to basically make clot. Okay, so a couple of hot topics. I talked about the Valsalva maneuver already, and cooling. Is everybody cooling or thinking about cooling? So we're thinking about cooling patients, and the question is really how cool to make them, and people are talking about 36 or 33. So the old school was really everybody's got to be cooled down to really post-resuscitation, cool them down all the way down to 33, so 91 degrees Fahrenheit. And now people are saying maybe you don't have to. It's been a year out since the trials. Maybe you don't have to. And now people are saying, well, really those people don't do as well. And the key looks like is preventing fever after resuscitation. So you have a code, somebody has an arrest, basically you get return of spontaneous circulation, but the person doesn't wake up. For the last few years, we've been making those people cold. There were 2 big articles in the New England Journal that said if you make those people cold, therapeutic hypothermia, you can drop their temperature down and they'll do better. And it's a 5-fold increase. Of the unconscious people that go to the ICU, it's a 5-fold increase of people who survive to waking up and going out of the hospital. So it's a huge advantage. So a lot of people are using cold saline. I know Northeast PA, we use cold saline to drop their core temperature down. And it's basically a 3 to 6 hour process, even 12 hours to get their temp down. And the question is where's the sweet spot? So for pre-hospital, it's really going to be think about cooling, get people cold. My favorite case of one of these was we had a guy who was a school teacher. He's a jogger. He had a cardiac arrest. They brought him in. He was V-fib arrest, they shocked him, brought him in, totally unresponsive, flaccid, not paralyzed, no movement, blown pupils. Really looked at the guy, I thought this guy's going to be like vegetative. There's just no way. And the fortunate thing, it was December. They found him in a snowbank. He had fallen on the side of the road. So he already was cold. We kept him cold in the unit. 3 days later, he wakes up. He rejoins, goes back to teaching. So it's really amazing what cold can do. It's a perfect case of, pre-hospital hypothermia where we dropped his temperature right from the start. But anyway, so the question is going to be going forward is how cold to make these people, and that'll be interesting. Peds intubation. Any you guys talking about this in the field? Out west, actually they looked at it for their numbers. I think it was New Mexico looked at peds intubation and said the average paramedic will intubate a kid once in a 30-year career. Like in New Mexico, they looked at their numbers, and so they're really saying maybe we should just bag the kids. If you're only going to intubate one kid in your entire career, maybe we should just bag the kids. So peds intubation, up or down, which way they don't go for critical care. And then we talked about Valsalva. Good. So that's a Valsalva video, which I ran in the beginning. So just apneic oxygenation, think about this in your practice. Bring the head of the bed up. It'll help you with intubation. Keep the nasal cannula on. Pelvic binders are still the way to go, but Reboa may be coming. Dopes, think of the dopsomonic if your tube is obstructed. Think of tranexamic acid coming in the future maybe. So ramp the bed up. Get your angles better. And I think questions? So good talking to you guys. Any suggestions, let me know. This is the 21st year of the conference, and this is my 21st year of talking.